So hello and good evening, everyone. Can I quickly check in the chat box if my audio and video is good? Please let me know in the comment section if my audio and video is good. We'll start once I get a confirmation from your side. Okay, right. I think we are good to go. Right. So I'm happy to see good number of students taking the exam and good to see students writing these exams as a habit. Okay, so right. So I think we'll have a quick discussion on this topic of vasculitis. So for those who are joining in YouTube, well, this is the discussion of the 10 multiple choice questions, the exam of which has been just conducted in the DocTutorials app. So Monday midday quiz, every Monday we are conducting a short quiz on a small topic. This time it is vasculitis, and that discussion is what we are going to do right now. Remember, it will be a very concise, crisp discussion. I'm not going for a detailed discussion. So I want each one of you to focus on the question. I'm just going to go for a very concise discussion. All right, so let's start. Okay, so very short discussion, just 20 minutes. So let's quickly run through this topic. Are we good to go? Right. So the first question, testicular pain is most commonly associated with which vasculitis? Now remember, vasculitis, as you all know, is a condition associated with inflammation of the vessel wall. And the involvement of the blood vessels in certain vasculitis can be predominantly involving large vessels, in certain vasculitis, medium vessels, certain vasculitis, small vessels. Depending on which vessel is involved, the manifestations can vary. For your competitive entrance exams, it is very important to know the key features of the individual vasculitic syndromes. Obviously, there will be certain clinical features like rash, purpura, fever, arthralgia, which can occur with multiple vasculitis. But certain clinical features are unique, and one such unique clinical feature is testicular pain. Okay, so remember, testicular pain is a unique feature in a vasculitic syndrome, that is polyarteritis nodosa, which is a medium vessel vasculitis. Okay, it is a unique feature which is not commonly seen with any other sort of vasculitic syndromes. You can see this table from the Harrison's textbook as well, and which shows the different manifestations of polyarteritis nodosa. The common manifestations are in fact involving the renal vasculature, especially the renal artery, resulting in renal failure and hypertension. But a rare but yet important manifestation is testicular, ovarian, or epididymal pain. But for the entrance exams, this is important and has been asked before. Let's go to question number 2. Okay, so question number 2. Temporal artery duplex ultrasound shown in image is suggestive of. Is it polyarteritis nodosa, giant cell arteritis, microscopic polyangiitis, or Churg-Strauss vasculitis? Now, I know that at least some of you who would have given this test may not exactly know, looking at this ultrasound, what exactly is it showing. But at least you can use your logic. Remember, in entrance exams, everything is not just about having knowledge. Sometimes common sense also works. You can see it is the temporal artery duplex ultrasound. And among the various vasculitic syndromes, which is that vasculitis which mainly involves the temporal artery, giant cell arteritis. And if you look at the image that is given in the question, you can see that there is a region of blood flow, but are you able to appreciate that just surrounding the region of blood flow, there is a hypoechoic halo-like region. Yes, hypoechoic halo-like region. And do you know what is this sign known as? This sign is referred to as the halo sign. This sign is referred to as the halo sign. Okay. So the temporal artery duplex ultrasound can show homogeneous wall thickening, which is the halo sign, And what is the reason for this? You know that giant cell arteritis can involve the superficial temporal artery. The vessel can be dilated and tortuous. So there can be an increased diameter. So what can happen is that the thickness of the temporal artery will be more, and that will be shown as this hypoechoic region. This particular region that you're seeing, this is in fact the thickened temporal artery. Thickened temporal artery is what is being shown. Yes, that is shown as the halo. So this is what is referred to as the halo sign, and halo sign is a feature of giant cell arteritis. I think we are clear regarding this. Any doubts on these two questions? Please let me know. Any doubts on these two questions? Okay, good. Let's go to the third questions. Okay, third question. 40-year-old male was seen with a history of recurrent oral ulceration. Now, this is a key word. A very important key word is this one. Okay. No other symptoms. Past history includes posterior uveitis and aseptic meningitis. Now, my dear students, when you get such sort of questions in your exam, which is involving more than one body system, you see here, the patient has got an oral ulcer, he has got an ocular involvement, he has got a neurological involvement. So keep in mind those multi-system diseases. Like, for example, vasculitis, connective tissue diseases. These are all multi-system diseases. So that is what you should be looking for in the options. And he's also having certain painful erythematous lesions in the anterior shins. Okay, so cutaneous manifestations are also there. And the lab evaluation shows mild normocytic anemia. What is the diagnosis? Now, remember, this feature in your exams, in entrance exams, a patient with multi-system involvement and important recurrent oral ulcers, you should think of an important vasculitic syndrome, that is Behçet's disease. Behçet's disease. See, oral ulcers can occur due to multiple reasons. But when you get oral ulcers in the context of a multi-system involvement, you should definitely think of Behçet's disease. And if you look at the Harrison's textbook, you will see there is a criteria for diagnosis of Behçet's. There is one important MCQ in that which has been previously asked. They have asked previously, which is the most common manifestation of Behçet syndrome? Most common. They'll give you oral ulcers, genital ulcers, skin lesions, eye lesions. So these will be the options. Can you tell me what is the answer? It is oral ulcer. Almost 100%. You can see here 98. Almost 100% of patients will be having oral ulcers. So if in your exam, if you get an MCQ and you're thinking of the answer of Behçet's disease, always make sure that the question has oral ulcers as one of the manifestations. Genital ulcers may be seen, skin lesions, especially erythema nodosum, pseudofolliculitis, papulopustular or acneiform nodules. Eye lesions can be seen either anterior or posterior uveitis. And the test that is used is the pathergy test. Okay, so these are some important findings that you should know. Okay, so what is going to be the answer here? Yes, oral ulcers, uveitis, aseptic meningitis. So all these actually point towards Behçet's disease. Let me ask you one additional point. Behçet's disease can produce brainstem strokes, very important. And can you tell me which part of the brainstem is likely to be involved by a stroke due to Behçet's disease? Answer is midbrain. Behçet's disease is very well known to produce midbrain strokes. Very, very important. Okay, right. So that is also clear. Let us go to the next question. As I said, I'm just keeping the discussion very concise and crisp. In the evaluation of a patient with suspected Henoch-Schönlein purpura, which of the following investigations is least useful? I suppose the answer key that was given is wrong, I suppose, because I saw that, just after the test got over, I got, at least 100 messages of students telling that, sir, in one of the questions, the option is wrong. You're absolutely right. I think the explanation given in the app is right, but somehow due to a technical reason, the option is wrong. So do not worry, when we calculate the winner also, I'll just try to take into account this question as well. I'll just try to change the answer. So in the evaluation of patient with suspected Henoch-Schönlein purpura, least useful investigation. Now, Henoch-Schönlein purpura, as you all know, the IgA vasculitis is characterized by the triad of purpura, colicky abdominal pain, and arthritis. Yes or no? Yes. Now, if you look at this, which of the following investigations is least useful? Now, look at option A, urine routine and microscopy. Remember, HSP can have involvement of the kidney. It can have involvement of the glomerulus, and because of which there can be glomerulonephritis. So since there is glomerulonephritis, I am expecting some sort of RBCs and RBC cast. RBCs and RBC cast. So that is one investigation that is going to be useful. What about complete blood count? Remember, Henoch-Schönlein purpura, my dear students, Sayak, Ashish, Sunny, Shubham, tell me this, Parth, tell me, Henoch-Schönlein purpura is a thrombocytopenic purpura or a non-thrombocytopenic purpura? It is a non-thrombocytopenic purpura. So what is the utility of complete blood count? It is important for assessing the platelet count because you have to rule out other differentials of thrombocytopenic purpura. For example, TTP. TTP is a thrombocytopenic purpura. So in the evaluation of patients with HSP, it is important to do the CBC to rule out thrombocytopenic purpura. What you're expecting in platelet count, there is no thrombocytopenia. You're not going to expect thrombocytopenia in HSP. Skin biopsy, is it important? Definitely is important. Very, 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 very important point that in HSP, the skin biopsy is diagnostic. Remember, the skin biopsy, what will you do? You will do immunofluorescence, and in immunofluorescence, you will see deposition of IgA and C3 in the mesangium. IgA and C3 deposition in mesangium. That is what you're going to see. So what is the best possible answer here? It is chest X-ray. It is chest X-ray. Among the options, the least useful is the chest X-ray. Should you do a chest X-ray? You should do. But the question is, among the following, which is the least useful? It is chest X-ray. Okay, that is clear. Let me go to the next question. Okay. Next question, 72-year-old woman presents with complaints of new onset headache. So it is an elderly patient with a new onset headache. She is fatigued and has lost 2.3 kg of weight over the past 1 month. So as a clinician, this tells me that there is some sort of a systemic illness, which may be an inflammatory condition, or it could be a malignancy, something. There is a weight loss or an infection also, a chronic infection also is possible. But let's see the remaining part of the question. The patient is having bitemporal headache. So some headache in an elderly. Always remember, elderly patient, new onset headache, one of the differentials is giant cell arteritis. Do not think that every elderly person who comes to you with a headache is having giant cell arteritis. But you have to take into account other symptoms as well, because vasculitis is most often a multi-system affection. Keep reading the question again. You can see that the patient is having morning stiffness for around 1 hour and an aching pain in the shoulders and hips. Can somebody tell me, in the context of a suspected giant cell arteritis, what is this symptom? Shoulder and hip stiffness. What do you think? Aching. What do you think? This is called a PMR. Kya hai PMR? PMR is polymyalgia rheumatica. Okay. Polymyalgia rheumatica. Okay. Polymyalgia rheumatica. And I've taught you in my lectures that patients with PMR usually have got stiffness, pain, aches in the shoulders and the hips. Now, it's not just that. And PMR, remember, is very commonly associated with giant cell arteritis. Can polymyalgia rheumatica occur as an isolated entity? Possible, but many a times it is coexistent with giant cell arteritis. Patient also reports loss of vision in the right eye for 30 minutes yesterday before her vision returned. Physical examination unremarkable. Laboratory studies showed normocytic normochromic anemia and a raised DSR. Raised DSR again suggests some sort of infection, inflammation, or malignancy. Now you see here, this is what is troubling me. Okay, she's got a transient loss of vision, which came back, but again, that is a red flag sign. Now, what is the next most appropriate step? It has been wrongly given. I repeat, it has been wrongly given in certain MCQ books and apps. Many students often ask me this doubt. Have no confusions. If a patient with giant cell arteritis is having a visual manifestation, there is no time to wait. You will not go for a biopsy. Yes, biopsy is important. But here, what you have got to do is start parenteral steroids as soon as possible. Don't choose the answer as temporal artery biopsy. Temporal artery biopsy is if, patient is having headache, no visual symptoms, you have got time to confirm the diagnosis and start the patient on oral steroids. But here, will the steroid alter the biopsy result? There is a mild possibility, but still just remember, if you simply start, if you just go for if you take your time, go for a biopsy and then start the treatment, by the time you go for the biopsy, and after a few days, the biopsy result will come, and then you plan to start the treatment of the patient. He's already lost his vision. Okay, so there is no point waiting. You have to start parenteral steroids as soon as possible. Okay, don't have any confusion on this. Wrongly given in guidebooks and all. Okay, so this is parenteral statements. Remember, giant cell arteritis with visual manifestations, start steroids as soon as possible. Without visual manifestations, you have got time. Go for biopsy, confirm, and then start steroids. Okay, because as obviously steroids can alter the biopsy result slightly. All the following features are used to distinguish polyarteritis nodosa from microscopic polyangiitis. So as you all know, this microscopic polyangiitis entity was previously referred to as microscopic PAN, microscopic polyarteritis nodosa. But now that term does not exist. It is microscopic polyangiitis. Now let us see the options. Option number 1 is ANCA positivity. Well, ANCA positivity, you know that microscopic polyangiitis, MPA, is having a P-ANCA positive. Okay, microscopic polyangiitis is P-ANCA positive, whereas in case of polyarteritis nodosa, it is ANCA negative. PAN is ANCA negative. So is it useful? It is useful. RBC cast in the urine. Remember, microscopic polyangiitis is a small vessel vasculitis. Polyarteritis nodosa is a medium vessel vasculitis. So if you look at the renal vasculature affection, polyarteritis nodosa can involve the renal artery, whereas microscopic polyangiitis can involve the glomerulus because glomerulus is a small vessel. Okay, so there will not be glomerulonephritis in case of polyarteritis nodosa. So remember, if the patient is having any sort of RBCs and RBC cast, that would be seen in case of which condition? It would be seen in case of microscopic polyangiitis. Okay, the next option, HBV infection. So hepatitis B infection is very closely associated with which condition? Polyarteritis nodosa. 10 to 30% of patients with polyarteritis nodosa, they often, have got associated hepatitis B virus infection because hepatitis virus, the antigen can act as a trigger for this vasculitis. Okay, right. So that is also clear. Okay, so the last point is necrotizing vasculitis. Remember, both polyarteritis nodosa and microscopic polyangiitis, both of them have got necrotizing vasculitis. So they're asking all the features are used to distinguish except. So if this feature is common to both conditions, how will it help to differentiate? It will not help to differentiate. Fine, perfect. Next question, what is the most common renal lesion in cryoglobulinemic vasculitis? Is it minimal change disease, MPGN, FSGS, or membranous nephropathy? So cryoglobulinemic vasculitis is also a small vessel vasculitis, and this will fall under the group of immune complex mediated vasculitis, and renal disease can happen in 10 to 30% of patients. Important. And what is the most common renal lesion in cryoglobulinic vasculitis? Very, very important. It is membranoproliferative glomerulonephritis. You can also expect a clinical scenario-based question on the same. And what will be the clinical scenario-based question? A patient with hepatitis C infection, okay, developing some sort of joint pains, arthralgia might be there, okay, purpura might be there, and then you might have some sort of glomerular involvement as well. So remember, hepatitis C is very commonly associated with cryoglobulinic vasculitis. Very, very important. It is a previous question as well. So patients can develop frank nephrotic or nephritic syndrome. Okay, but most of the time, the patient presents with milder degrees of glomerular involvement in the form of microscopic hematuria or proteinuria. So answer for this is option B. Okay. Next question. 44-year-old female presents with recurrent uveitis and scleritis. Okay, so there is some sort of ocular involvement. Patient is having again nasal discharge and shortness of breath. Okay, chest X-ray reveals cavitary lesion, so lung involvement. So again, we are dealing with a multi-system involvement. So every time in the exam, you watch out for such questions having multi-system involvement and think of these conditions like vasculitis and connective tissue diseases as well. Nasal mucosa is erythematous and reveals a perforation in the nasal septum. Among the vasculitis, you tell me which is the one that is likely to involve the nasal septum. Mohammed Rizwan, Deebu Jacob, Joshua George, can you tell me which is that one? It is Wegener's granulomatosis. Wegener's granulomatosis. And what is the new name of Wegener's granulomatosis? Granulomatosis with polyangiitis. Because sometimes they may not have this Wegener's in the option, they might give granulomatosis with polyangiitis. There is no evidence of any sort of synovitis, rash, or mononeuritis. What is the likely diagnosis? Now, at least some of you, you might have been carried away by the first statement, ocular involvement, because when you learn the disease Wegener's granulomatosis, the typical sites of involvement are the upper respiratory tract, lower respiratory tract, lower respiratory tract, and the kidney. So you can have upper respiratory tract involvement, lower respiratory tract involvement. So in the question, you can see definitely there is involvement of the lungs. And nasal mucosa and nasal septum, again, very commonly involved in Wegener's. As I said, when you learn vasculitis, try to learn the signature features of individual vasculitic syndromes. But also remember, it is not limited to these three important anatomical regions alone. You can even have ocular involvement as well. So ocular involvement in the form of uveitis and scleritis also can occur in case of Wegener's granulomatosis. Hence, the answer here is Wegener's granulomatosis. And in nasal septum, what is the name of the deformity? Can somebody tell me? Rizwan, what is the answer? It is saddle nose deformity. Okay, so Wegener's granulomatosis will have saddle nose deformity. See, always in your exams, you have got to think like a clinician. Okay, it is important to think like a clinician, which will help you answer such questions with confidence and ease. It's when you try to mug up all the clinical features of one disease and put in your head, that is when you start confusing yourself. So that is when you get these questions wrong, but stay relaxed. This one is a simple question. Okay, right. Now, the next one, bronchial asthma is a common presentation of which vasculitis? Again, as I said, this is a signature feature of another vasculitic syndrome. And what is it? It is Churg-Strauss syndrome. Remember, the pulmonary manifestations of Churg-Strauss syndrome, which is also known as EGPA, eosinophilic granulomatosis with polyangiitis, includes a late onset or an adult onset asthma, which is often refractory to the conventional treatment. Patient also may be having some sort of patchy and shifting pulmonary infiltrates, sometimes nodular infiltrates without cavitations. So when you get infiltrations in the lungs, there are different vasculitic syndromes that can have pulmonary infiltrates. You can have Churg-Strauss, Wegener's, microscopic polyangiitis, but cavitations, you should think of which one. Is it GPA or EGPA? GPA. Granulomatosis with polyangiitis is where you get cavitations along with the infiltrates. In EGPA, usually cavitations are not seen or cavities are not seen. Pleural effusions, diffuse interstitial lung disease, and rarely you can have pulmonary hemorrhage. Okay, so that is also clear. And going to the next question, most commonly affected blood vessels in Takayasu arteritis. Okay, so see, when you discuss this, at least some of you would have got this question wrong. I'm sure many of you would have got it right. So Takayasu arteritis, we know that it is also known as aortic arch syndrome. Aortic arch syndrome. Now, at least some of you might think, is aorta the most common blood vessel involved? No, because sometimes names can be deceiving. Okay, you have heard about the posterior inferior cerebellar artery syndrome, the Wallenberg syndrome, the lateral medullary syndrome. But if you're asked what is the most common blood vessel involved in the lateral medullary syndrome, is it pica? It's not pica. It's known as pica syndrome, but pica is the second most common blood vessel involved, and the most common blood vessel involved is the vertebral artery. That's why I said, names can sometimes be deceiving. Okay, right. So here, I just to show you with more conviction, this is a table in Harrison showing the involvement of various vessels in Takayasu arteritis, including the percentage of abnormalities. Remember, subclavian artery is very commonly involved, and watch out for arm claudication in the history, sometimes absent pulses, reduced pulses in the upper extremities. Then you can have iliac vessel involvement, which can lead to leg claudication. So arm claudication can be there, leg claudication can be there. Raynaud's phenomenon also can occur due to subclavian involvement. And you can have carotid involvement leading on to stroke as well. You can have abdominal aorta involvement, aortic arch involvement. Patient can have high blood pressure. There can be renal involvement. Okay. And Takayasu arteritis is, again, a very important cause of a renal artery stenosis. Renal artery per se is a medium-sized vessel, but can also be involved in case of Takayasu arteritis, though Takayasu arteritis is a large vessel vasculitis. And always remember, Takayasu arteritis is also referred to as pulseless disease. So you can see unequal pulses between the extremities. So unequal blood pressure. These are all possibilities in case of Takayasu, though they can frame questions in different manners. Okay, so what is the answer here? The most common blood vessel that is involved is the subclavian artery. I have also seen one question where they have asked least commonly affected blood vessel. And the answer at that time was actually pulmonary artery. Actually, coronary is even less frequently involved. But in that NEET PG question, they gave option as pulmonary and coronary was not there. So if coronary is there, that is the least commonly involved blood vessel. But otherwise, the second least common blood vessel involved is the pulmonary artery. Okay, that's it. So that's it. We have had a very short, crisp discussion of the 10 questions. So I know that one of the questions, the key given was wrong, but do not worry. The explanation given there is correct. And I'll try to, announce the winner after taking into consideration that particular question as well. And then, in the groups, I'll announce, who the winner is. But just let me know, are you enjoying the Monday midday quizzes? And if you want, or if you have got any suggestions for a particular topic, because, we have done topics like stroke, myocardial infarction, vasculitis. So just let me know if you have got any sort of suggestions for the topic for the next quiz. I'll just announce maybe tomorrow or day after. I'll be announcing the topic also in the groups. But see, what I want you to do is that I want you to make these quizzes as a habit. Please don't have inhibitions. Are these exams for me? I'm not a topper. See, you have to keep improving yourself. You may not be a topper now, but why don't you try? Why don't you put consistent efforts? It will take time, but slowly and steadily you should improve. You all are young doctors, and it is very important to have persistence. So if you keep working hard and have confidence in yourself, you can definitely scale up your preparation. Okay. So thank you so much, everyone, for joining. And do share this video with your friends and batchmates. And let's all, attend the next quiz together, and waiting for the discussion of the next quiz as well. Thank you so much. And yeah, thank you so much. Good night, everyone. Thank you.